Dr. Rajalakshmi, the next speaker, Dr. Rajalakshmi Rajshekhar. And may I request Dr. Manjunath to chair the session, please?
It's my great pleasure to introduce Dr. Rajalakshmi Rajshekhar. I am very happy to say that she was my MBBS student also at JSS Medical College. She is the 4th rank holder in MD Pathology from Rajiv Gandhi University of Health Sciences. She did her MD from Mysore Medical College. She has 14 years of teaching experience. She is trained at Tata Memorial Hospital, Mumbai in hematology. She has 18 national and international publications on her name. She has participated as a panelist in panel discussions, presented in oral papers in state, national and international conferences. Over to Dr. Rajalakshmi.
Thank you, sir, for your kind introduction. At the outset, I would like to thank the organizers, Mindray and BLK Max Super Speciality Hospital, and my principal institution, and Dr. Deputy Director of Laboratory Services, Dr. Manjunath, who is here, and my professor and HOD for this research, which is possible now, and I'm able to present it here in the forum. I would also extend my special thanks to Mr. Biju, Application Specialist from Mindray, for the acquisition of data. So today I am presenting automated FRC count in Mindray BC 6200. That is the instrument we have in our institute. So here the study was to evaluate the effect of microcytosis and poikilocytosis on the automated counting, that is automated FRC count in the Mindray analyzer. So schistocytes, which are formed after mechanical intravascular destruction of erythrocytes, are major signs of micro and macroangiopathic hemolytic anemia. All of us know the causes of micro and macroangiopathic anemia, so I'll just move on to the next slide. So there is a recommendation by the ICSH, the International Council for Standardization of Hematology. So the guidelines in 2021 update says the recommended reference ranges for healthy adults and full-term neonates as more than 1%. More than 1% of morphologically identified schistocytes on the blood film are considered suspicious for thrombotic microangiopathy. Whereas for preterm infants, the count is suggested, recommended by ICSH is more than 5%. So this ICSH has defined schistocytes as always smaller than intact red cells and can have the shape of fragments with sharp angles and straight borders, small crescents in the form of helmet cells and keratocytes. So these are counted under oil immersion microscope, oil immersion objective. Minimum 1000 RBCs are counted, and even then we can find inter-observer bias. So the fragmented RBCs are also generated by the autoanalyzers, hematology analyzers nowadays, and there is a suggestion that the absence of FRCs can be used as a valuable parameter to exclude the presence of schistocytes on the blood film. So coming to the principle of FRC detection in Mindray BC 6200, this is evaluated in the red channel using a fluorochrome fluorescent dye. So that stains the ribosomal RNA of the reticulocytes. Forward scatter in this red channel, diff scatter plot, it shows the blood cell size, while fluorescence intensity displays the RNA content. So this is well known. And the FRC as depicted in this representation is between the reticulocytes and the optical platelets which are measured. So this is the window for FRC, which is highlighted there with a dotted circle. So these are the values which are given by the RUO parameters, that is research use only parameters by Mindray, which gives the FRC, that is fragmented red cells, in absolutes as well as percentages. So the estimation of FRCs by analyzers warrants a mandatory blood film analysis after the FRCs are flagged by the analyzer and the count is given by the analyzer to assess actually the real count of the FRCs. The conditions presenting with microcytosis could influence automated FRC count exhibiting a false high FRC value. And this was inferred after observing some of the slides, some of the cases of microcytic hypochromic anemia where there was flagging for fragmented RBCs, and the FRC count approximately nearing to 1% was given by the analyzer. So a literature search was done where I came across a study where there was interference of microcytosis, where there was a study on the interference of microcytosis and hypochromasia on the Sysmex analyzer. The result was just there was no interference of microcytosis, whereas hypochromesia did interfere with the automated FRC counting. Whereas there were no studies available on the interference by poikilocytes. So this study was taken up to evaluate the accuracy of automated FRC estimation in hemolytic anemia by the analyzer in the presence of microcytosis and anisopoikilocytosis. So the objectives were to evaluate the accuracy of automated FRC counting in hemolytic anemia compared with the manual method, and to assess the interference of microcytosis and anisopoikilocytosis in automated FRC counting. So a total of 76 cases of hemolytic anemia were included. Among these, 47 cases were extravascular hemolysis, 29 cases were intravascular hemolysis. A control group of 86 normal subjects were also taken to look for the FRC and other parameters in the analyzer. And then a group of 73 cases of microcytic hypochromic anemia were also included in the study to look for the interference of microcytosis and anisopoikilocytosis with FRC counting. All these indices were acquired from Mindray BC 6200. So the results were the 29 intravascular hemolysis cases comprised of MAHA, that is microangiopathic hemolytic anemia, 1 case of definitive TTP, 2 cases of HUS2, G6PD deficiency 5 cases, cold agglutinin induced autoimmune hemolytic anemia 15 cases, and then extravascular hemolysis thalassemia, sickle thalassemia combination and sickle cell anemia, hereditary spherocytosis, elliptocytosis, and 4 cases of autoimmune hemolytic anemia, WORM. So this is the scatter plot that was obtained from the red channel. So we can see here there is an overlap of these blue cells in the FRC area. That is the first case of thalassemia, which is giving an FRC percentage of 8.7%. The next photograph is of the sickle thal case where the FRC count was 9.9, and we can see the blue dots in the FRC area. And the next one was thalassemia with 11.5% FRC count. This is in contrast with the normal scatter plot is down there, where the FRC area is not showing any blue cells. So moving on to the blood pictures which were analyzed simultaneously. This is a case of thalassemia. The arrows, red arrows, are pointing towards the broken RBCs, which are actually indicative of schistocytes, and manually these were actually counted. This is the next case of sickle thalassemia, where the arrows are pointing towards the schistocytes along with the sickle cells which are shown in the picture. Then we have the cases of intravascular hemolysis. The first case is of a cold autoimmune hemolytic anemia with fragments FRC of 12.5%. Then we have MAHA, microangiopathic hemolytic anemia, with FRC of 7.9%. And looking under the microscope, these are classic helmet cells and keratocytes, which are triangular shaped broken abscesses or schistocytes. And this is the case of interest where in microcytic hypochromic anemia, the arrow is pointing towards the smaller poikilocytes, which are actually picked up by the analyzer as fragmented RBCs, which is giving a percentage of 3.6%. And here again in the scatter plot, we can see there are some blue dots in the FRC area, whereas on microscopy they were not true schistocytes, but they were just smaller poikilocytes. So this is the final result of all the cases in all the 4 groups. The group 1 extravascular hemolysis, the mean FRC percentage was 2.2, whereas manually it was only 1.4%. So there was an overestimation by the analyzer. And then we have the group 2 intravascular hemolysis, where the FRC percentage is 4.3, and manually we could get a mean of 3.3%. And in the group 3 microcytic hypochromic anemia, the mean FRC obtained by the analyzer was 1%, whereas manually all those were smaller microcytes or poikilocytes which were analyzed by the instrument in the FRC area as fragmented RBCs. So that is a false positive result in the microcytic hypochromic anemia group. And in the normocytic normochromic blood picture, which was a control group, the analyzer gave a mean FRC percentage of 0.3%. So this is the correlation of manual FRC versus automated FRC in group 1. This is in group 2. So the Spearman correlation coefficient is 0.933 and 0.884 respectively for extravascular and intravascular hemolysis, suggesting a good agreement between the instrument as well as the manual method of estimation of FRC. So the Mann-Whitney U-test also showed a p-value that is 0.1 or 0.4. That means there is not much of statistically significant difference between the manual as well as the automated count, suggesting a good agreement between the assessment of FRC by the analyzer and the manual method. So Bland-Altman plot for extravascular hemolysis shows most of the values which are outside the 95% confidence interval, whereas in intravascular hemolysis we can see most of the dots values are within the 95% confidence interval. So this suggests a high degree of